Assalamualaikum doctors. In this video I am discussing how can we manage the celiac disease history. So management plan is that I will examine the patient carefully, take his measurements and plot on the growth chart. I will assess his dehydration status and ABCD, airway breathing circulation, dehydration status. I will involve my senior or even my consultant if need for admissions, and I will run some tests. The investigation for celiac disease are: number one, diagnostic. Initially, if symptomatic on high risk group, then total immunoglobulin A and immunoglobulin A TTG. So total immunoglobulin A and immunoglobulin A NT-TTG. This is the test. If total immunoglobulin A is elevated and immunoglobulin A NT-TTG is positive, refer for the pediatric GI to continue the investigations. If immunoglobulin A NT-TTG is more than 10-fold the upper normal level, immunoglobulin EMA, another blood sample. If immunoglobulin A EMA positive, then diagnosis is celiac disease. So first we are doing immunoglobulin A, total immunoglobulin A and immunoglobulin A NT-TTG, both are positive. Then we are doing EMA test. If immunoglobulin A NT-TTG is more than 10-fold normal and EMA test is positive, then it is diagnosis of celiac disease. But if TTG is positive but less than 10-fold or EMA is negative, then we do the biopsy. If TTG is negative, review the initial total immunoglobulin A. So we understand that what are the tests we are doing. Immunoglobulin A TTG and immunoglobulin A NTA TTG, both are positive. Then we do the EMA test. EMA test positive, that is celiac disease. Here immunoglobulin NTA TTG is more than 10-fold. If immunoglobulin A NTA TTG is less than 10-fold and EMA test negative, we need to do the biopsy. If risk of a false negative serology, then we are doing the HLA-DQ2 and HLA-DQ8. HLA-DQ2, HLA-DQ8, if possible, follow and retest on a normal gluten intake. Consider biopsy. Indication for biopsy I am telling: if TTG positive but less than 10-fold, the upper limit. If TTG is more than 10-fold but EMA negative. If immunoglobulin A is low and immunoglobulin G is high plus positive EMA. If in annual review, if the serology is still high or symptoms not improved. So indication for biopsy are: number one, if TTG positive but less than 10-fold. Number one, TTG is more than 10-fold but EMA negative. Number three, if total immunoglobulin A is low but total immunoglobulin high immunoglobulin G plus positive EMA. In annual review, if the serology is still high or symptoms not improved. Lab we are doing HLA-DQ2 and HLA-DQ8. Other autoimmune screening: diabetes and thyroid, full blood count and iron study, ESR, CRP, stool analysis, microscopy and culture, bone profile and RBS. Screening for the other family members. With TTG, if low, so normal, and if high, we will proceed to genetic testing. If negative, so normal, and if positive, then we will proceed to biopsy. So other we are doing HLA-DQ to HLA-DQ8, full blood count, ESR, CRP, thyroid profile test we are doing, diabetic screening we are doing, RBS. Also we are doing the iron study, we are doing stool analysis and microscopy we do. Radiology we are doing abdominal ultrasound and DEXA scan, upper endoscopy and biopsy finding. That is endoscopy and biopsy and gluten challenge test. Gluten challenge test: if the child is less than 2 years, positive family history of celiac, if diagnosis uncertain, if false negative biopsy. Give at least 10 to 15 gram of gluten for 6 weeks, then do the serological test. If positive, so proceed to biopsy. So for the management purpose, we will involve the multidisciplinary team: pediatrician, my consultant, dietitian, GIT, orthopedic, endocrine, psychological support to the child and the family, liaison with the school and about his condition. Again, multidisciplinary team, we are involved by pediatrician, my consultant, dietitian, GIT, orthopedic, endocrine, psychological support to the child and the family, liaison with the school about his condition. Follow up at the time of diagnosis: full blood count, thyroid function test, calcium profile and random blood sugar. After 6 months, full blood count, iron profile, calcium profile, screening for complications. After 1 year, repeat the duodenal biopsy, serological test. Annually, weight, height, and Tanner staging. Review the symptoms, reassess the compliance to gluten-free diet, DEXA scan and bone profile every 2 years. Repeat serology if increased. Referral to GIT consultant for biopsy and complication for side effect of the treatment. What is the advice about the nutrition? Strict gluten-free diet. That is fruits and vegetables, beans, seeds, legumes and nuts in their natal, unprocessed forms, eggs, lean, non-processed meats, fish, most low-fat dairy products with vitamin A, D and iron. Avoid food containing gluten leak like wheat, rye, oat, bread. So wheat, rye, oat, bread, cakes and pies, peas, candies, cereals, then communion offers cookies and crackers. These are avoiding. If not adherent to gluten-free diet, it will increase the risk of gastric lymphoma. Endocrine problem in celiac disease are short stature, delayed puberty, vitamin D deficiency with secondary hypoparathyroidism and osteoporosis, hyperthyroidism, diabetes mellitus. So endocrine problem, short stature, delayed puberty, diabetes mellitus, thyroid, hyperthyroidism, and vitamin D deficiency with secondary hypoparathyroidism and osteoporosis. Type of anemia in celiac are iron deficiency anemia, duodenal pathology, normocytic, normochromic anemia of chronic illness, macrocytic anemia for vitamin B12 deficiency, autoimmunohemolytic anemia. Then clinical spectrum of celiac disease. Symptomatic are symptoms and positive serology and histology. Silent are no symptoms but positive serology and histology latent. Symptoms only if eat gluten containing diet, normal histology but sometimes show gluten dependent enteropathy. Potential is maybe with symptoms or not, serology positive and negative histology. Celiac crisis. Now I am discussing about the celiac crisis. Celiac crisis is a rare initial presentation of the celiac disease characterized by severe diarrhea, dehydration, weight loss, hypoproteinemia, metabolic and electrolyte disturbance. Although rare, it should be considered in patients with apparently unexplained chronic diarrhea. Definition of celiac crisis is that acute onset or rapid progression of the gastrointestinal symptoms attributable to celiac disease requiring hospitalization and or parenteral nutrition along with at least two of the followings. First, signs of severe dehydration including hemodynamically instability and other orthostatic changes. Neurologic dysfunctions, renal dysfunction, creatinine is more than 2.0 gram per deciliter, metabolic acidosis, pH less than 7.35, hypoproteinemia, albumin less than 3.0 gram per deciliter, abnormal electrolyte including the hyper or hyponatremia, hypocalcemia, hypokalemic, then or hypomagnesemia, weight loss is more than 10 pounds. Management. How can celiac crisis we manage? First of all, initiation of the gluten-free diet, then parenteral fluid replacement and nutritional support and electrolyte correction, corticosteroids, IV like budesonide. Complications in celiac crisis are severe dehydrations, neurologic dysfunctions, renal dysfunction, creatinine more than 2.0 mg per deciliter, metabolic acidosis, pH less than 7.35, hypoproteinemia, albumin less than 3.0 gram per deciliter, electrolyte abnormalities, hyponatremia, hypocalcemia, hypokalemia, and hypomagnesemia. So this is celiac disease management and celiac crisis management. Thank you.